Well, from proms to prems, it's to PEECE and PEECH. Our last speaker on the panel is Professor AnneWilliams from Murdoch University. So Anne has spent a significant amount of time developing tools to measure patient experience. And so I'm just wondering, Anne, if you wanted to give us a bit of a summary of the work that you've been doing in the space of measuring patient outcomes.
Yeah, I'd love to, Pip. I'd also, I think at the end of the line here, going to give a bit of a perspective of the researcher, because we're measuring patient experience, and a lot of research is about measuring. So I think it's important that I talk a bit about that, because there may be a few researchers in the room, but I assume that not everybody is that, and I just want to clarify what research is, because I think that'll help you understand the instruments that I've developed and their place in terms of measuring patient experience. I started out as a nurse working on the wards in acute care hospitals, and here I am as a Professor of Health Research 30 years on. I changed direction and moved into research because I really felt that we could do better caring for patients in hospital, and that's driven me all the way along in terms of the work that I've done. And I've been a researcher here in Western Australia for over 20 years. I think the difference, or what's really helped with my research, is having a clinical link. I haven't just been based in a university, I've always been based in the hospital and had a link with the university. So my main association actually has been with Sir Charles Gardner Hospital all these years, and I continue that association now, working as a research consultant there as well as a professor at Murdoch. Research is really all about understanding what's going on. It's about looking at things carefully, closely, in detail to work out what's going on. Now, I'm telling you that because if you're going to measure something, you really got to understand what you're measuring and be sure you're measuring the right thing. If you're not measuring the right thing, you can go way off track in terms of the strategies or implementation that you might be using to treat something. And I'm talking here about health and illness. If you've got it wrong and you don't understand the core issue of the health illness, and you might be using the wrong medication, you might be using the wrong treatment. So that understanding is what's really, really important in terms of research. Now, in terms of research, research isn't just about statistics. And if it was, I would never have gone into it because I was never very good at maths. But research, there's two types of research. One is qualitative research, which uses interviews, stories, observations, words, descriptive words. And the other type of research is what you would know with the statistics. It's called quantitative research. What we tend to do in research these days, and I think the best types of research, are to use a bit of both, because so often you will find, and I've done multiple projects here in Perth, that if you just use a questionnaire, just use numbers, you don't necessarily understand what the results mean unless you've talked to the people in the situation as well and gathered that qualitative data as well to explain what the results mean. And sometimes we get the strangest results. And I don't know how we would ever have interpreted them if we hadn't done some interviews as well to find out what really was going on in the situation. So that understanding and looking at things from different perspectives is really important. And that's what's been great, listening to everybody talk here, because look at the different ways that we're trying to measure patient experience. We're not just gathering numbers, we're talking to people, we're doing all sorts of things. And I think over the years that I've researched in patient experience here in Perth, what I've come to understand is how complicated it is. It's not just one thing that I needed to understand, it's multiple things, and I still don't understand it. There's so much I don't understand, but what I do understand is we need to look at it in different ways and consider different factors if we're going to have any chance of really pulling together some evidence about what's going on. Okay, now I can talk about what I'm supposed to be talking about. So when I did my PhD, which I finished in 2003, I did a project in Perth which explored the experience of patients in hospitals, particularly in regards to the interpersonal interactions that they experience. So that's the way that people communicate with you while you're a patient in a hospital. And that was everybody that communicated with the patients, the nurses, the doctors, but also other patients, cleaners, everybody that talked to the patient in hospital. And what came from that was an understanding that actually if you receive positive interactions from people generally, it could actually help facilitate a therapeutic state of emotional comfort, which helped you to heal, helped you to be more likely to participate in activities which would facilitate your healing. So the interactions of people in hospital were really, really important. I interviewed 40 patients in hospital here in Perth. I did 78 hours of field observations, sitting in wards with patients, watching the interaction with various people, and I also interviewed 32 nurses. I did it over 5 years, and that's the only project I did over 5 years, and I really did a lot of thinking over that time and analysing and working out what was going on. And I used a method which was a qualitative method called grounded theory. So at the end of that, I developed a theory about the patient experience, which I called the emotional comfort theory. And that's why I was saying emotional comfort is central to understanding what was going on for the patient, because that was the state that patients perceived helped them to heal. So what came from that was a lot of detail about the interactions that patients perceived to be positive and the interactions perceived to be negative. But that was only from 40 patients. And I know from a research point of view that I needed to have a look at a wider sample of patients to see what was really going on in different hospitals at different times. And so I developed a questionnaire which is abbreviated as the PEECH, which measures the emotional care that patients receive in hospital. So that's the interpersonal interactions they experience in hospital. And that is based completely on all that data that I gathered for my PhD. It's a short questionnaire, it's only 15 questions, and it's given to patients while they're in hospital. They're asked to reflect on what's happened to them in the past 24 hours in terms of the interactions they've experienced. We've done all the clever statistics on it, which has brought it out to be reliable and valid, which is what they say in research terms. And the questionnaire has been picked up by quite a few other researchers throughout the world, and it's been translated into different languages now, and it's being used probably mostly in the United Kingdom, and used as a research instrument to try and improve patient care, and used as a measure to see if certain interventions that are being implemented can increase the emotional comfort of patients. So, for example, there's one project going on in the United Kingdom at the moment with older patients, where the nurses are being educated in increasing their compassionate care interactions, and so PEECH is being used to evaluate whether that education is actually improving the care that the patients are experiencing in the ward areas. Another project that's used the PEECH has actually also mapped the well-being of the nurses caring for patients in a number of various different hospitals in the United Kingdom. And the findings from that study showed that where the well-being of the nurses was low, and nursing's a very stressful job, a very demanding job. Nurses do suffer actually a lot with stress, and when they are stressed, they don't deliver as higher quality care as you would like. And that's actually coming out as quite an issue in the nursing profession at the moment. And I'm doing a project on that as well. So that's the PEECH instrument. And that was developed in 2008. And the other instrument, which is just ready for publication now, is called the PEECE. And the PEECE measures emotional comfort, actually the phenomenon of emotional comfort. So it's got questions like the patient might be asked to, there's a question, I feel calm, I feel relaxed, and then you work out how, a lot, a little, that's the sort of questions that are in the PEECE questionnaire. And the idea of that is that we'll be able to try out different interventions to help increase a patient's emotional comfort. And going back to the understanding that if you can increase the patient's emotional comfort, then hopefully it's going to improve their healing, which will translate into other things such as shorter lengths of stay and better recovery outcomes. So, so that's those two instruments. Now, we'll just touch on some other exciting news, really, in terms of measurement instruments in Australia, and just to let you know that at the moment, nationally, the Australian Commission on Safety and Quality in Healthcare is actually got a big project underway to develop an instrument to measure patient experience in hospital for inpatients and also patients who are coming in for procedures. And I'm on the expert panel for that, representing the nursing profession, which is a great honour for me. And it's really great to be able to contribute to the development of that instrument. And my understanding is that that instrument is going to be implemented across Australia, similar to the United Kingdom, who have an instrument called the PICA, Patient Experience Instrument. And that's widely distributed and analysed, and you can look on websites and see what's happening where patterns are there. So, so there's the research perspective for you, Pip.
Thank you very much.